Perfect. So thank you for joining our frozen shoulder webinar today. I know a lot of us are based in Canada, United States. So right now I'm based in Hamilton, where this snowstorm is rolling through right now. So if you are experiencing the same snowstorm as us, thank you for joining us while taking time away from doing whatever you guys had to do. So today we'll do the functional instrument assisted soft tissue mobilizations for healthcare professionals based on the frozen shoulder course. So let's just give a little bit of a background about our programs and what we actually do. So M2T-Blade.com. So M2T-Blade stands for Myofascial Mobility Tool. We developed the M2T, which is a all-in-one use tool that replaces 8 or 9 tools that you may have. We also created a Vigor tape, which is a chill kinetic black tape. We developed courses on proper utilization of M2T, corrective mobility exercise selection, and integration into practice. We're currently located in Burlington, Ontario, and Pompano Beach, Florida. We also have an office in Manila, Philippines. Our courses are primarily for trainers, therapists, students, and doctors like yourself. All those courses are on M2T-Blade.com, or you can email us at support@M2T-Blade.com. So a few upcoming courses we have. So we're actually in Toronto at the end of next month in February, just North Toronto, Markham, at the Hilton Garden Inn. On that same day, on February 23rd, we're also in Moncton, New Brunswick with one of our instructors, Ricky. Then the week after, we're in Ottawa at Pro Physio, up in just outside of Ottawa. Then into March, we're in the middle of the Philippines. So in March, we're doing our level 1, level 2 in our taping at the University of the Philippines. Then the week after that, we're in Bangkok, Thailand. And then after that, we're in Myanmar, or also known as Burma. We're doing the first course for instrument-assisted soft tissue mobilization based in Burma. And Maneth will be teaching the Bangkok and the Burma courses. So if you do need to know any courses coming up, just email us at education@m2tblade.com. So one other thing we're doing here is that we have our custom tool. We're the only company that actually offers a custom tool. So with this, we have 6 colors. We have black, we have red, green, blue, silver, and rainbow. With these custom, you also get your logo, website, and name engraved as well. So for today with our webinar, we're offering a little bit of a cool thing for you guys. So here's a couple of the colors we have. We're giving you guys free shipping on all the orders. You get to customize your entire blade, and like we're the only company that actually offers customization. You get a choice of color, engraving of logo, and our website. You get one of our new wooden boxes. It looks like a cigar box and a pouch, and our online introduction course. 20% off for all webinar attendees. If you guys want to unlock this or take advantage of this, just email education@m2tblade.com for more information. So again, this is more of an educational thing rather than a sales thing. We just want to make sure you guys are aware of our custom tool, that you guys get some cool little things with that. Let's go right into our frozen shoulder. So our frozen shoulder IASTM course, we're the first guys to come up with specialization courses for IASTM. So how we can unlock frozen shoulder with these tools. So what we're going to talk about today. So in this webinar, we're going to go through about frozen shoulder, talk about the assessment, treating it using the M2T-Blade, and our corrective care program. So with our corrective care program, it's more based on our exercise and how to retrain the shoulder after the treatment. So we're not just about treating, we also want to retrain and re-strengthen that shoulder area. So after this specific course, practitioners will be able to thoroughly assess, identify, and correct adhesive capsulitis, also known as frozen shoulder conditions, with instrument-assisted soft tissue mobilization. So what is a frozen shoulder? So frozen shoulder, sometimes called adhesive capsulitis of the shoulder, is a condition where the shoulder becomes painful and stiff. Shoulder movements become reduced, sometimes completely frozen. It is thought to be due to scar tissue like forming in the shoulder capsule. Without treatment, symptoms usually go, but this may take up to 2 to 3 years. So this is a condition where it will resolve itself, but the patient will experience a lot of pain, discomfort, and lack of range of motion, and extremely affect their active daily living as well, or their ADLs, but it will dissipate 2 to 3 years. But again, we want to step in as health professionals to help to resolve and strengthen this issue so they are not in pain and not have a poor quality of life for that 2 to 3 years. So with frozen shoulder, there's 3 things we need to know. There's 3 phases, and each phase we're going to treat it differently. As a practitioner, it's extremely important to know what phase we're dealing with so we can apply the appropriate techniques, strengthen it, and get it back to where it's supposed to be. So the first phase is phase 1, which is also called the freezing phase. So we have a snowstorm here. I'm getting little bit of cold, but so phase one is the painful phase. This typically lasts 2 to 9 months. So they'll start feeling it if the condition starts. They'll start seeing it 2 to 9 months after. The first symptom is usually pain. So they'll get a idiopathic pain, a pain that comes out of nowhere in their shoulder. There will be no acute trauma. There will be nothing. Just one day they'll start feeling pain in their shoulder. Stiffness and limitation, and also gradually build up. So it becomes stiff, and the range of motion will decrease over time. The pain is typically worse at night when you lie on your affected side. Once we go out of phase one, we'll move into phase two, which is called the frozen or stiff phase. This is probably the worst phase to be in for frozen shoulder. This typically lasts 4 to 12 months. So the pain gets better, but the stiffness and limitation movement remain and become worse. All movements of the shoulder are affected. However, the movement most severely affected is usually rotation of the arm at work. So if I'm trying to bring my arm up and wash my hair, so we'll go into abduction and external rotation. The muscles around the shoulder may waste as they are not being used. So we'll start seeing some muscle atrophy in that region, infraspinatus, supraspinatus, anterior delt, medial delt. They'll start getting a bit of muscle wasting. So when we talk about our instrument-assisted soft tissue mobilization techniques as well, we have to keep in mind of what kind of strokes we're going to use, what kind of tissues we're going to resolve here. Once I move from the phase two, we're going to go into phase three, which is also called the thawing and recovering phase. This typically lasts between 1 and 3 years. The pain and stiffness gradually go, and movement gradually returns normal or near normal. So what is frozen shoulder? So frozen shoulder affects about 3% of adults at some stage in their lives. It most commonly occurs in people aged between 40 and 65 years old. It is more common in women. It is also more common in average people who have diabetes and some other conditions, including an overactive thyroid disease. Either shoulder can be affected, but most commonly it is the non-dominant shoulder, that is the left shoulder in a right-handed person. One in 5 cases, the condition develops in the other shoulder at some stage. So if you've had it in your left shoulder, 1 in 5 of those cases will go to the opposite shoulder as well. So just a quick note as well, frozen shoulder is not a form of joint inflammation, and other joints are not affected. So if we see this condition just in the joint, we'll see it within that joint. It's not going to kind of spread or feel the same symptoms in other joints. Why is it there? The cause is not clear. It's thought that some scar tissue forms in the shoulder capsule. So with the capsule is a thin tissue that covers and protects the shoulder joint. The scar tissue may cause the capsule to thicken, contract, and limit the movement of the shoulder. The reason why the scar tissue formed is not known. A frozen shoulder occasionally follows a shoulder injury. However, this is not usual. Most cases occur for no apparent reason. Previous injury and synovial fluid. A proper health history and examination is extremely important. With most frozen shoulder cases, there's limited or no synovial fluid within the joint. So we want to really make sure we take note of that as well. So when we're going through our instrument techniques, we want to improve the health of the shoulder joint and improve the synovial fluid in the joint. Because again, we want to create that movement. So current treatment plan. So a lot of people that have adhesive capsulitis or frozen shoulder, they're maybe getting a little bit of physio, maybe a little bit of massage, they're getting injections, rest, and some exercises, which is all good, but we're going to kind of focus on our treatment program. So our treatment program is assess, correct, and retrain. So our treatment program is we're going to first assess the thoracic spine and the muscles of the shoulder. We want to create health and a lot of movement throughout the thoracic spine, so it helps take pressure off the shoulder joint and improve the range of motion of the shoulder. When we do this live course, we go through a lot of techniques to improve thoracic mobility using the M2T-Blade. Today, we're just going to talk about it, kind of give you guys some insight of how to attack the thoracic spine. Then we'll also look at the muscles of the shoulder. We're going to do a little bit of range of motion within the limits. We're also going to test those muscles and palpate those muscles as well. Once I assessed thoracic spine, muscle of the shoulder, we're going to our treatment. So our primary thing is improve thoracic mobility. There's lots of techniques we can do with the M2T-Blade. Then we're going to decrease the myofascial adhesions within the joints and improve the weaknesses within the scapula. Once I've done that, we're going to do our correctives. So we'll have 2 sets of correctives that we'll talk about today. We have isometric agonist antagonist retraining, which we're going to start off with isometric agonist antagonist retraining. We're going to focus that with stage 1 and stage 2. Once I get my patient into stage 3, we'll go more into our active PNF and our active mobility work because we'll have that range of motion back. We just have the muscle wasting, which we need to strengthen. Progression. So the frozen shoulder is a long-standing injury where there's damage and lack of synovial fluid and excessive myofascial adhesions to the joint. As practitioners, we need to follow a progressive treatment program, which includes mobilization and corrective exercise. So I just want to make sure that So mobility for stability. So we want to create mobility in a pattern before we stabilize a pattern. So we want to find out what muscles are not moving and create mobility and then move into our stability muscles. So let's talk about myofascial adhesions. I know in a couple slides previous, we talked about we need to treat those myofascial adhesions and find them, but what actually is a myofascial adhesions? So fascia is a connective tissue within the body. Think of your entire body wrapped in fishnet hose, both internally and externally, including each individual bone, nerve, and muscle. Over time, fishnet hose gets entangled and require adjustment. If not, you'll develop impingement. Our fascia is going to work in the same manner. Once the fascia becomes entangled, impingement may occur. It may impinge blood flow, circulation, muscle movement, or nerves in the body. Over time, myofascial adhesions occur as a result of unintended impingements. With frozen shoulder, we'll see the lack of mobility, lack of hydration, lack of blood flow in those tissues. So those muscles will start developing myofascial adhesions, even though there's been no direct or acute trauma to the shoulder, we'll start seeing it build up within those tissues. So here's a cross-sectional picture here. We can see two tissues that are slide and glide over another. So in the human body, every muscle is supposed to slide and glide. In the shoulder, we have a ton of muscles that overlap each other. If we have friction, lack of hydration, lack of blood flow, we'll develop and those muscles get stuck together. In our clinics, we always say it's like saran wrap or sticky wrap. If I put saran wrap or sticky wrap together, the two pieces will get stuck and we can't pull them apart. If I put some water between the saran wrap or sticky wrap and I try to slide and glide it, we'll have a little more of that slide and glide through those tissues. So how to fix myofascial adhesions? So I know we talked about frozen shoulder. Now we're going to take 2 steps back and talk about instrument-assisted soft tissue mobilization. So instrument-assisted soft tissue mobilization, when the tissue is damaged, it will heal in a disorganized pattern, forming adhesions and scar tissue. These adhesions will lead to limitations in range of motion and increase in pain. So I'm not talking about damage as if I get punched in the shoulder, if I fall, dislocate my shoulder. Damage could be just overworking that shoulder, could be bad posture. Like we see a lot with frozen shoulder cases. We have kyphosis of the spine. That's why we're really big on fixing that thoracic spine, improving that mobility. So how it works. So scar tissue and adhesions prevent the fluid movement of muscle, tendon, ligament, and fascia. As our M2T-Blade instrument glides over the adhered tissues, the stainless steel tool will reverberate the feeling in our hands. Like a stethoscope amplifies the sound of the heart, instrument-assisted soft tissue mobilization tools such as the M2T-Blade series assist us in finding the exact areas of restriction. These tools are going to help us break down scar tissue, and over time this process will reduce or eliminate the adhered fibers, restore function, and decrease pain. So the blade. I know there's a few people on this webinar that don't have a blade or haven't seen a blade before, so just a little bit of background. If you do have it, this is just a good review for you guys as well. So M2T-Blade means myofascial mobility tool. So we're trying to create mobility within the myofascial system using our blade. It's the only tool with a double beveled edge with both a superficial and deep treatment edge. We have 8 treatment points to affect all areas of the body. We have an integrated handle for increased control and outcomes. Can be used in either hand. It's made in Canada. It's also made out of stainless steel. So we use a 0.316 surgical grade stainless steel. That means it's a non-porous stainless steel. So if I'm using it on my patient, it doesn't trap skin cells or dirt or debris, and cleaning it becomes very easy as we can just wipe it clean. So and this picture is actually a little bit outdated. So right now we're in over 42 countries. Like we talked about, we're in Burma. We had a couple other clients from I'm drawing a blank on the countries, but there are about 45 countries that we teach in right now. We're just expanding to doing our stuff in Myanmar and Burma as well. Here's a picture of our tool. This is one of our new images. If you want this image for your clinic, just send us an email at support@m2tblade.com and we can send it over to you. So treatment edge 1 and 2 was used for our assessment and superficial treatment. Then I go counterclockwise, 3, 4, 5, 7, and 8. These are all the tools within one tool that we can treat every muscle in the body. We do have a new handlebar that we use more for sport-specific stuff in larger muscle areas like the quads and hamstrings, but the M2T-Blade is really good just to use for every muscle and it replaces a whole toolkit. So tissue assessments. Your assessment should include global movement, range of motion, strength, and tissue quality. So when I'm looking at frozen shoulder, we don't want to just go towards the shoulder. We want to look at everything from the ankles, knees, hips, low back. And we talk in our live course, we go a little more into our hips, into our ankles, and how our actual posture and movement can affect the frozen shoulder through our gait. So we want to look at the entire body, not just the shoulder. So we're going to start off with global movement testing, which is your functional testing like squatting, lunging, pushing up, range of motion. Then we go into our muscle and strength testing. Once I've done my muscle and strength testing, I will move into my soft palpation. So we always want to palpate the tissues prior to us assessing with our blade. Once I've done the soft tissue palpation, we're going to assess with the M2T-Blade. So the blade is big for assessing and treating as well. Like we talked about 10 slides previously, we're going to use that as we're going to find out where those myofascial adhesions are. Once we find out where those myofascial adhesions are, we will treat. Then we'll retest the same ones we did. So we'll go back to our soft tissue palpation, muscle strength testing. Then we're going to move into our correctives. So assessment steps, like we talked about, global assessment, range motion, strength, palpation, assessment with the blade. So using the M2T to detect faulty tissues. Once the area of interest has been narrowed down by the assessment, the M2T is used to find specific areas of restriction. So once we've done our muscle testing, we find out what muscles are weak, what muscles aren't really moving, done a range of motion, we can use our tool to go over those adhered tissues and find out exactly why they're not working. We're going to do a technique called sweeping. So we're going to sweep through the actual tissues, and we'll get a tactile feedback through the tool into your hand. Once we feel that, we're going to treat those exact areas, help break them down. So treating with the M2T-Blade, so emollient cream or lotion should be used. We always apply, we always recommend using a cocoa butter. It smells good, it's hypoallergenic, and it comes off the skin very easily. Tissues should be treated from superficial to deep. The M2T must always be held at a 45-degree angle to the targeted tissues. The M2T can be push or pull, but should only be used in one direction at a time. Only moderate pressure to the tool is used. We only recommend about 5 to 8 pounds. When we actually do our live course, we put our hands on each of the practitioners and we put the force through. We don't want to create a ton of force through the tool. We just want to have about 5 to 8 pressures just so you're engaging the actual tissue and not creating any damage to the tissue. And stroke speed. So there's going to be two kinds of stroke speed. Should be two types of stroke speed. So fast, short strokes, we want to facilitate the muscles. So if I have any muscles that are not working up the speed, so with frozen shoulder, we'll typically use our fast, short strokes. We want to facilitate those muscles and make them move better. If I want to make the muscles relax, say the upper fibers of traps, it's always overworked. We want to do slow, long strokes. So contraindications. So just like any other massage technique or manual therapy technique, some contraindications are going to be, we just got to be careful with open wounds, high blood pressure. We got to really take back our stroke speeds. Thin skin, so if we have an elderly population, we don't want to be as aggressive because the skin may be a little bit thinner. And then any kind of sunburns and stuff like that as well. So now we're going to move into a little bit of our anatomy stuff of what muscle we're going to treat. We're not going to talk about too much about anatomy. We're just talk about some of the muscles that we need to look at with frozen shoulder. So first one, like we talked about before, is the thoracic spine. So we have the muscles we're going to really want to look at here, as we can see the lats, lower traps, mid traps, and upper traps. A lot of the times with frozen shoulder cases, again, this is not a cookie cutter approach, but you guys need to assess each patient, is that we're going to see the low traps and mid traps not functioning very well. So we need to do those fast, short strokes to help facilitate the low traps and mid traps. If I take those away, we have our rhomboids here. You start seeing our infraspinatus, our supraspinatus, the attachment of the levator scap, and our teres major, teres minor. We have our serratus in posterior superior and our serratus posterior inferior as well. Those muscles too are going to really affect the ribs. And if someone has that kyphosis spine and they're really protecting their shoulder, these muscles are going to be shut off as well. So we need to really work within the serratus anterior and the serratus muscle to help with ribs and proper rib breathing too. Another deep thoracic spine. The muscles here we're going to look at is the intercostals in between the ribs. We're going to work on all those muscles. So we'll use treatment point number 8. And then we're also going to look at the multifidus and rotatories as well. So conditions, dysfunction, limitation. So when we look at the thoracic spine, we're going to look at our rib dysfunction, erector strain, perispinal strains, rhomboid strain dysfunction, and our mid-lower trap dysfunction. So with these muscles are decreased T-spine rotation, and we'll see our flexion extension. So all those muscles we talked about above, that's what we're going to look at here. So we move to our treatment with the blade. We're going to focus on treatment point 1 or 2 for those large muscles. Then we'll move into treatment point 3 and 8 for the deeper perispinal and rotatory muscles. So our patient's going to be prone, sideline with arm abducted, or if you want in the seated position, they'll be seated and slouched with the arms crossed in front of them. From there, we go into our cervical spine posterior. So here we're going to see the upper fibers of traps, and we'll also see all the suboccipital muscles as well. These muscles with frozen shoulder are going to typically be overworked. We have to do that slow, broad strokes. And just a little bit of a picture of our perispinals here as well. So with conditions, dysfunctions, limitations, we'll see suboccipital headaches, thoracic outlet syndrome, or TOS. First rib dysfunction, so you want to check out that first rib as well. Make sure it has proper mobility. And then WAD, which is whiplash-associated disorders. We don't see too much of the whiplash-associated disorders within frozen shoulder cases. For treatment, so with our treatment, we'll use treatment point 3, 6, or 8. Patient will be prone or supine. When I'm working on the suboccipitals, I'm going to work towards the midline, and if I'm working on the perispinals, I'm going to go away from the skull. If I go back towards my upper fibers of traps, I'm going to go towards the midline as well. Okay, then we go to our posterior shoulder. So here are a lot of the muscles we're going to want to look at. So we're going to see our two of our triceps, infraspinatus. We're going to see a little bit of our supraspinatus and our levator scap. And a little bit of a deeper angle here as well. So you can see those rotator cuff muscles. These are all muscles we're going to muscle test and really work on for frozen shoulder. With the positional stuff, we're going to work on doing fast, short strokes, get those muscles working and improving the range of motion within the shoulder capsule. So with these muscles here, we'll see decreased internal and external rotation, scapular dyskinesis, meaning the scap's not moving very well, and adhesive capsulitis. We'll see a lot of impingement and rotator cuff injuries as well. When with these muscles too, if we can start seeing glenohumeral joint degeneration, we're going to work on those tissues to prevent that from happening. Treatment, so treatment point 1 or 2 for the deltoid, treatment point 2 or 3 for the muscular and rotator cuff. So our patient here is going to be prone or sideline with the effective shoulder superior or above. We're going to use our free hand to control the motions and find those increased lines of tension. And the anterior, so we'll spend more time working on the anterior shoulder. So here on the left-hand side, we'll see the pec major coming across our anterior deltoid. A little bit of upper traps and our scalenes. We're going to take away the pec major and anterior deltoid. We'll see our pec minor, short-headed biceps, and long-headed biceps. Remember, these attach right to the scapula as well, so we really need to work on pec minor, biceps, short head, and long head. Here's another picture here as well. See a little more of the subscap underneath that bicep tendons as well. So conditions, dysfunctional limitation. So again, we'll see our adhesive capsulitis. We may see a little bit of bicep tendinopathy as well, and we'll have to look at our AC joint too. So treatment point 1 or 2 for the deltoid, pec major, and bicep brachii. Treatment point 3 for the pec minor. We can have the patient either prone or sideline. So if we want to get into that pec and subscap, we'll have them more. I prefer to have them sideline. Again, we'll use the free hand to control the arm and find lines of increased tension. So let's go into our isometric agonist antagonist retraining. So we assessed, we found out what's going on with the thoracic spine, anterior shoulder, posterior shoulder. We treated it using the blades. We did our, for the muscles we want to facilitate, we did our fast, short strokes. The muscles that are overactive, we did our broad, slow strokes. Now we want to retrain the shoulder and improve the range of motion. So in phase 1 and phase 2, we'll use our isometric agonist antagonist retraining. So this is a technique to reestablish a neurological firing pattern that a muscle experiences with normal corrective or rehab exercise without putting a dynamic load or stress to the muscle or joint. After an injury or repetitive strain, the receptors to the muscle, ligaments, tendons, and fascia are altered and may say abnormal signals and are fished back to the brain. That's why with frozen shoulder, this may take so long. We want to kind of break that pattern, improve that range of motion, get those muscles to work. So when a muscle or joint is injured, movement may be impaired, which will increase the activity of the nociceptors, which creates pain around the joint. So if I have an increase of nociceptive activity, I'm going to have a decrease in mechanoreceptor activity. So with frozen shoulder, we saw phase 1, painful, increase in nociceptive activity, then we'll have less movement within the shoulder. So mechanoreceptor activity is reduced and joint movement is restricted. Isometric agonist antagonist will increase mechanoreceptor activity, which will influence the nervous system at the spinal level and inhibit nociceptor activity. Hence why it feels better to move an injured area. So why we do this after instrument-assisted soft tissue mobilization? When an area has sustained an injury, the soft tissue or movement pattern, there will be limited neurological firing, blood flow, and nutrition to the area. When I do this technique after IASTM, we'll improve the neurological response, prepare the tissues, and retrain the impaired muscle or movement. So how do we do it? Just like the appropriate muscle testing, the practitioner or trainer will shorten the intended muscle while applying a perpendicular force that matches the strength of the tissue or movement for 7 seconds. Once completed, the practitioner or trainer will perform the same technique to the antagonistic muscle. So if I'm doing this on my biceps, I'm going to put the bicep in a shortened position, apply a force that matches the force of the patient for up to 7 seconds. Then I'll go to the triceps. I'll put the arm in the position that shortens the tricep muscle, apply this technique again, going back and forth 3 to 5 times. You should see a gradual increase in strength and movement. So once I've done that in my phase 1 and phase 2, and I got my patient more in a phase 3 where they have that increase in range of motion, we need to improve the strength and mobility of the actual shoulder. We'll move into active PNF. So dysfunction can be related to a disruption of the neuromuscular system. Improving the system should then create more effective movements. In order to improve the neuromuscular system effectiveness in coordinating movement, proprioceptive, and neuromuscular facilitation, concepts should be utilized in this last phase. So the muscles must be worked synergistically in order for movement to occur. This requires a muscle to have a reflexive ability to contract and relax in order to perform basic movements. Fundamental movements such as squatting, lunging, and stepping are PNF patterns that all rely on the body's ability to effectively create, control, mobility, and stability. So again, we want to kind of create that, with frozen shoulder, we want to create that abduction and external rotation. So we'll use like a band or some hand weights, just go through that movement. So abduction, external rotation. Slowly strengthen those muscles to that movement pattern and going through that full range of motion. So how do we do it? So isometric contraction of the agonist followed by isometric contraction of the antagonist. We're going to produce co-contraction and stability of the 2 opposing muscle groups. So that's our entire webinar here. If you have any questions, you can email us at support@M2T-Blade.com. So just a little bit of a recap here. We do have, these are the 5-6 colors that we have. So we also, I sort of forgot to mention the rose gold as well. If you want this, you get the free shipping plus 20% off your order. You get your own logo engraved right into the tool, and you get to pick the color as well. If you would like this 20% off customized blade, just email us at education@m2tblade.com, and we'll send out a link as well. Also, if you like the recording, we did record this today. Just send us a quick email at education@m2tblade.com, and we'll send you the recording within the next few hours. Thank you, and I hope you have a great day today.